Good morning, everyone. And I'd like to thank Dr. Trilokraj Tejasvi for inviting me to this session. And I'll be talking about teledermatology and telemedicine, bridging the gap and Indian perspective. We've already heard the one from New Zealand and from Europe. I think this is rightly said by Dr. Anne Burdick that the teledermatology train is coming. Get on board, get out of the way, or get run over. In today's world, we cannot help but be interested in teledermatology. It is the future. Definitely, this is an alternative to the face to face communication, which uses electronic telecommunication tools and facilitates delivery of care between the provider and seeker. Now, the main motives of teledermatology, which is to reach the underserved population, to break barriers of disability and saving costs, I think this is very rightly put together from the Indian perspective because we have a very large country, a very diverse population from the north to the south and the east and the west. And I think all these three things are very pertinent to our setup. We have a huge number of underserved population. So this is an article by Kantraj, way back in 2011, where the dermatologist community in India is indeed clustered around urban areas. These are the metro cities. We call them the tier 1 cities. You also have the tier 2, tier 3, which are tiny cities in remote areas. So Gramstat is the satellite communication based technology for rural India. Now, this is provided by the Indian Space Research Organization, or ISRO, and is a telemedicine pilot projects. SATCOM, on the other hand, are bus to remote geographical regions. These establish satellite network connectivity with a tertiary center. So this is how it was almost a decade back. Increased collaboration between the dermatologists and the primary healthcare providers, because there are areas where you don't have dermatologists again. So these are the primary healthcare provider, which could just be a GP. Now, the rural area faces severe shortages, making teledermatology crucial for bridging the care gap. Now, this is another article by Anmol Sethi, how the teledermatology evolved in India. An early adoption was seen way back in 2000s when India did begin experimenting with teledermatology. However, the COVID-19 pandemic is the one which really caused an acceleration, and there's a major increase in teledermatology consultations in 2020. WhatsApp, Zoom, and eSanjeevani OPD were the most used platform. Now, even this eSanjeevani OPD was set up by the Ministry of Health and Family Welfare, and this was like having these teledermatology clinics about twice a week, like we've also done it in our hospital. I come from Lady Hardinge Medical College, a tertiary hospital affiliated to Delhi University, and all of us were doing these e-Sanjeevani, teledermatology consultations. This led to a high patient satisfaction rate for the teledermatology services. A few success stories. This is a study from Shillong, which is Northeast India. Now, Northeast India is very remote, usually a hilly area with far-flung cities, mainly the tier 3 cities that I'm talking about. So here they did a study on the clinico-epidemiological profile of patients availing the teledermatology services at a tertiary care center in Northeast India. So the common cases here included acne, eczematous condition, and superficial fungal infections. Of course, patients are, little reluctant about a lot of other conditions. Majority of the patients were urban. The benefits were faster diagnosis, early treatment initiation, and reduced tertiary referrals. On the other hand is the Karnataka teledermatology model. This is a huge state in the southern part of our country. Now, this is implemented in the primary health centers, the PHCs across rural Karnataka. As I mentioned, these are tiny stations, which have either a general practitioner or maybe just a general duty medical officer. Moderate reduction in referrals to tertiary hospitals led to better local care. The key challenge, however, is in training primary care providers to use the teledermatology tools, because this does need a bit of training. Now, the government initiatives by the Indian government driving teledermatology growth. Now, this is by the Ministry of Health and Family Welfare India. The government programs which have now been initiated, say, over the last 4 or 5 years. I mentioned the e-Sanjeevani OPD, which has had over a million teleconsultations in 2021, and it receives both pictures as well as also, telephonic calls, and it's a kind of a pro forma that is made in which we supply the prescription to the patient. This has been quite successful. The National Leprosy Eradication Program also incorporates teledermatology to eliminate leprosy in all districts by 2030. It's better to reach, all the remote areas. There is also integration with the government's ambitious Ayushman Bharat scheme to expand teledermatology under India's digital health mission. This is something that provides medicines at a very reasonable rates, to all the populations, especially the poorer populations. Now, of course, there are challenges and barriers in Indian teledermatology, as is likely in a very huge country. Internet and technology barriers. Majority of rural India lacks high-speed internet. It does have internet because everybody has the smartphone and the internet, but the high-speed internet is lacking, limiting real-time video consultations. Although the smartphone access is increasing, but data cost remains a challenge. This article by Thomas and Kumar P says that there's also a misdiagnosis risk because the image quality varies due to inconsistent lighting and smartphone cameras. So this is something that we face also in the e-Sanjeevani OPD. Somebody may just have taken a picture which may not make any sense. So that is again something that needs to be pointed out. Need for AI integration to improve diagnostic accuracy and standardization. Legal issues in teledermatology in India. Now, this was a bit of an issue before because teledermatology prescription needed to be countersigned by a registered medical practitioner in accordance with the Drugs and Cosmetic Rules 1945. This could be an issue sometimes. And the IT Act 2000, which defines security, privacy, and confidentiality of patient data and potential misuse and even abuse of the electronic records. So in super session, the Board of Governors in super session of the Medical Council of India, this is the main council, medical council that we have in India, the National Medical Council. These are now the telemedicine practice guidelines, which say that the RMPs can practice telemedicine while following ethical and professional standards. Patient identification and consent are mandatory before consultation. Appropriate technology and mode must be chosen based on clinical judgment. Prescription rules restrict certain drugs and require proper documentation. They did give a list of drugs that these are the ones you can apply, give to the patient as A, B, and C, and rest is only on a face-to-face consultation. Data privacy and ethics must be maintained as per legal guidelines. There are also guidelines for telemedicine services in Ayushman Bharat Health and Wellness Centers. Now, this is the hub and spoke model. The medical colleges act as hubs, providing teleconsultations to the primary health centers, which are the PHCs, and health and wellness centers, HWCs. So these are actually bigger centers, the health and wellness centers, the better centers. So the e-Sanjeevani platform developed by the Center for Development of Advanced Computing, CDAC, enables video consultations, e-prescriptions, and health record integration. The infrastructure has the HWCs, which need telemedicine kits, desktops, and internet, and hubs require doctors, specialists, and IT support. This is important. The stakeholders are the Ministry of Health and Family Welfare in India, state governments, CDAC Mohali, and hub nodal officers who manage the implementation. Training and monitoring is done regularly with regular staff training and dashboard-based tracking, which ensure efficiency. Now, regarding the role of artificial intelligence and teledermatologist, as I said, there's only one dermatologist for 400,000 people in India, with majority of them concentrated in the urban areas. So artificial intelligence-driven image diagnosis does increase the list of differential diagnosis when we're using it even at the remote areas or with the primary health centers. Even for skin cancer diagnosis, this is better. Limitations, however, are that not all diseases may be in the database, and in the future, integration of image and other patient data is something that can be really done. Regarding the data safety and compilation, what is proposed is each healthcare provider would have a unique provider identifier, and this would flow to all its programs and telemedicine consultation centers, which are the TCCs. The telemedicine specialty centers and the TCCs would have a separate unique and universal identifier code. Each patient, on the other hand, would also be identified by a unique and universal patient identifier. And there would be one central patient information record which can be assimilated. Comprehensive medical databases can be built. So this is again work in progress. Regarding the data safety and compilation, so here again the issues is who can access individual health information. So coding and encryption is required for storage and transmission. And there was a problem about suggesting essential investigations, but now you can actually suggest essential investigation. So all this is being done. It's still work in progress, but it comes with a disclaimer which has to be made. The advice is based on relatively limited understanding of a patient's condition. Doctor's best intent is to help the patient within probable and feasible means. This is important. And whole teledermatology-based advice is not a treatment in itself to a large extent. So thank you so much.